Kawaguchi, chairing the session, and speaking with us today on the management of pulmonary hypertension in systemic sclerosis is none other than Professor Hidakita Yasuoka. Professor Kawaguchi, please.
Okay. Hi, good evening. So a little bit 10 minutes or 12 minutes late. So I would like to start this session. This session topics is systemic sclerosis, scleroderma, especially pulmonary arterial hypertension. Today's speaker is a very, very ideal speaker. Professor Yasuoka is one of the most famous professor of the field of systemic sclerosis in Japan. He has many publications of basic research and clinical research in scleroderma. Little bit, I'd like to introduce him. Professor Yasuoka is a medical doctor with an MD degree from Keio University and also PhD degree from Keio University School of Medicine in Tokyo, Japan. And he moved to the University of Pittsburgh Medical School, and he studied many fields of systemic sclerosis. Dr. Professor Thomas Metzger. And he has been certified by several boards, including the Japanese Society of Internal Medicine and Japan College of Rheumatology. He's a member of several professional and scientific societies. And also he has received several honors and awards for his systemic sclerosis research. Professor Yasuoka, unfortunately, he is now is not here and online. Are you ready to speak, Professor Yasuoka?
Hello, Dr. Kawaguchi.
Okay.
My name is Hidakata Yasuoka, so I'm online. So can I start?
Okay. Start. Please start.
Okay, so I will share my slides. So let me start. Let me upload my slide. Okay.
Okay. Slide is not working.
No, it should. I'm sorry. Wait for a moment. Okay, so can I start?
Slide is not working. Still, huh?
No.
Okay.
Okay.
Okay. Okay.
So thank you very much, Professor Kawaguchi, and thank you very much for organizers for having a chance. And my name is Hidakata Yasuoka from Fujita Health University, Aichi, Japan. I'm going to talk about management of pulmonary hypertension in systemic sclerosis. So this is my COI. So I'm going to talk about pulmonary artery hypertension, PAH. The pulmonary artery hypertension is caused by the narrowing of the pulmonary artery or arterioles and upregulation of the pulmonary artery pressure, and which results in the right heart failure. Usually, mean pulmonary artery pressure normally 14 plus 3 millimeter mercury, and threshold is 20 millimeter mercury, as Kavak reported. So the definition of pulmonary artery hypertension is mean pulmonary artery pressure was above 25 millimeter mercury. Pulmonary artery wedge pressure is below 15 millimeter mercury, and PVR, pulmonary vascular resistance, was above 3 units. This is a new definition of pulmonary artery hypertension, and mean pulmonary artery pressure was decreased to 20, and PVR was decreased to 2 units, suggesting that we should detect PAH much more earlier than expected. Anyway, I also talk about connective tissue disease, Kogenbyo in Japanese. Connective tissue have three characteristics One is rheumatic disorders as clinical concept, connective tissue disorders as pathologic concept, autoimmune disorders as immunologic concept. This is general disease course of connective tissue disease, which is started from injury and trigger, and usually infiltration of immune cell will be seen. And then inflammation will induce damage and repair. And if wound healing is physiologic, it's going to the regeneration. But it's going to the pathologic, remodeling and fibrosis will occur. Connective tissue disease will go this way and then accumulates remodeling and fibrosis, which results in the organ damage and poor prognosis. Anyway, I'm going to talk about CDD-PH today because CDD-PH is thought to be a population who have the worst prognosis among all PH categories. This is the clinical classification of pulmonary hypertension reported in the 2022 ESCRS guideline. Classification is not changed so far and classified into 5 cases: Group 1, pulmonary arterial hypertension, pulmonary hypertension associated left heart disease, pulmonary hypertension associated lung disease, and pulmonary hypertension associated pulmonary arterial obstruction, and pulmonary hypertension with unclear multifactorial mechanism. Connective CDD-PAH is classified into 1.4.1 here. This is a background disease of connective tissue disease in CDD-PAH. This is a kind of single-center study in Japan, and as this slide shows, MCTD, mixed connective tissue disease, SLD, systemic lupus erythematosus, and systemic sclerosis is the major disease in Japan. But when we go to other Asian countries like China, Taiwan, and Korea, SLE is a major disease. On the other hand, when we go to Europe, systemic sclerosis is a major disease. So there might be some of the ethnic factors for the onset of the CDD-PAH. So let's go to each disease, and this is SLE. The SLE is, as you all know, as a prototype of systemic autoimmune disease. SLE should have the various organ involvement shown here, but it doesn't include the pulmonary hypertension, because pulmonary arterial prevalence of pulmonary arterial hypertension is relatively low in SLE, like 3%. But this prevalence is relatively high compared with idiopathic pulmonary arterial hypertension. When we look at the histological finding of pulmonary artery, blue slide shows the SLE. SLE doesn't have the pulmonary fibrosis or pulmonary vascular change, but it has the immune cell infiltration, suggesting that SLE-PAH is associated with disease activity of SLE. So usually when we treat the SLE-PAH and other non-SSc-PAH, we usually use immunosuppressant, including high-dose glucocorticoid and cyclophosphamide. The aim of the treatment is normalization of the hemodynamics. Usually, pH drug, including PD5 inhibitors, is combined with immunosuppressant. So let's go to systemic sclerosis. Systemic sclerosis, as you all know, has the triad: fibrosis of skin and organs, microvascular injury, and autoantibody production. But we have to manage the fibrosis and remodeling, but we do not have so much good treatment for this kind of management. Systemic sclerosis also have various kinds of organ involvement, including the cardiopulmonary involvement, gastrointestinal involvement, microvascular involvement, and myoskeletal involvement. These organ involvement can determine the prognosis in SSc. And for example, when we look at the death frequency of death, PAH and ILD is the most frequent cause of death in scleroderma recently. And also, when we look at the mortality, patients with PAH have a very poor prognosis like this. 2 years survival is around 40% in natural cause. When we look at the histology of the scleroderma in red, they show the pulmonary fibrosis and pulmonary vascular change here. There's not so much infiltration in immune cells, suggesting that fibrosis remodeling is a major pathogenesis of scleroderma. So we have to manage the fibrosis or remodeling, but there is no good treatment so far. And also in scleroderma, complex abnormalities in pulmonary circulation can be observed. Many patients have not only the pulmonary artery involvement, but also the lung and heart involvement, and also the pulmonary vein involvement. So not only pulmonary arteries, but also other regions can be involved. So evaluation of other organ involvement are important. So based on these backgrounds, the prognosis of SSc PAH is much poorer than non-SSc PAH. So for the improvement of prognosis of the SSc PAH, we have to have the development of novel treatment approach and early diagnosis, in addition to community awareness and education. However, we don't have not so much good treatment so far. We need early diagnosis and screening for the improvement of the prognosis. This is one of the good example of the showing the significance of active screening in SSc PAH. So its systematic detection program means the screening in asymptomatic patients, and routine clinical practice means follow up the patients in the symptomatic patients. When we compare these two groups, the prognosis is quite better in systematic detection program, suggesting that active screening helps improvement in prognosis in SSc PAH. So we have to think about how do we grab earlier cases. So there is two approaches, and screening aggressively and focusing on high-risk group, or developing novel screening methods. So let's go to the first one, focusing on high-risk group. So there is some reports mentioning about the high-risk group, including patients, SSc patients with limited cutaneous scleroderma, anti-centromere antibody, duration more than 10 years, and telangiectasia. In some reports, pulmonary function test results are also combined in here. So these are very high-risk group, so we can detect PAH patient effectively using this kind of high-risk group. But systemic sclerosis itself is a high-risk group for pulmonary arterial hypertension. So recent guideline mentioned that in patients with CTD-PAH with overlap feature of SSc, an annual evaluation of the risk of PAH may be considered. Borderline MPAP cases are also another risk factors. And borderline MPAP is formally defined in MPAP between 20 to 25. This population can develop pulmonary hypertension much more higher compared to normal MPAP cases. If we follow up more than 5 years, more than 30% of patients will develop the manifest PAH, whose hazard ratio was 3.7. But when we interpret the borderline MPAP cases, we have to be careful about that. This is a result from Farrell's registry, and this includes the 28 case with borderline MPAP cases. But more than half of the cases had significant ILD defined by the pulmonary function test and high-resolution CT scan. So let's go to the developing the normal screening methods. And first one is combination of several indicators to increase sensitivity. So this is the detect algorithm, one of the good example called detect algorithm, which is the evidence-based screening algorithm for sclerodermal PAH, which is consisted by the 6 non-echo variables as step 1. And if we have the high score, and then we will go to step 2. And then if we have a very high score, we will go to the right heart catheter test to examine to confirm the diagnosis. This algorithm was tested in SSc patient with over 18 years old, disease duration more than 3 years, and percent DLCO was less than 60%. Prevalence of PAH in this population is around 90%, which is higher than the normal population. And the aim of DETECT study is not to miss the PAH cases and standardization of modalities and the selection for right heart catheter test. So this DETECT algorithm is very good because they only missed the 4% of PAH cases, and overall sensitivity was 96%. So this algorithm are good not missing the PAH cases. However, the running cost is the issue, because once we use the detect algorithm, we need more than 200 euro per analysis. But when we look at the other analysis, it's only half of it. Also, detect algorithm is only examined by cross-sectional study, so we do not know how often we have to do that or when to do that. Also, patients identified the detect algorithm are not mild, but almost of the cases identified by detect algorithm was asymptomatic or very mild. But when we observe the patients after 1 year, around half of the patients have a progression, 40% have the exacerbation of functional class, 30% admitted to the hospital, and 20% have needs combination therapy, and 10% was died. So again, not all cases identified with DETECT are not mild. So let's go to the another screening approach called induced potential PAH by the artificial loading. So in this slide, as I already told you about new definition of the pulmonary hypertension, here is exercise pulmonary hypertension, and this means the exercise cardiac echo. And this is reappeared again in the new guideline again. So exercise is one of the good options to do that. And here is the interesting data, and using the 76 sclerodermal case, and the right heart catheter test was tested in at rest and during the exercise. So in 76 patients, 22 patients had manifest PAH, but 15% had PAH and 3 with ILD, 4 with chronic heart disease. Also, 21 patients with exercise PAH patients, 2 patients has chronic heart disease. So this means patients, not all precapillary PAH on exercise patients do not go to resting PAH. So natural history is not so clear by the stress echocardiography itself. So we have to carefully interpret the results of stress echocardiography. So based on these findings, here is a new recommendation in 2022 ESC ERS guideline. I do not touch the detail here, so please check the guideline and to lead with. So let's go to the treatment. As you all know, there is a frequency pH drug, enzyme pathway drug, no nitric oxide, and prostaglandin I2 pathway, 3 pathways here. So there is a trend of the change of treatment of sequence, and we usually use the combination therapy of these 3 classes of drugs. Formerly, we used the add-on therapy, in other words, the sequential combination therapy. But recent trend is upfront combination. It is because monotherapy did not improve the prognosis of SSc PAH compared to IPAH. This is a good example of the evidence of upfront combination therapy called Ambition study. So Ambition study was examining the combination of the ERA and the PD5 inhibitor compared with the food monotherapy. And prognosis is quite better in combination therapy. And that trend was also seen in CTD-PAH, SSPA-PAH by the forest plot. So based on these results, most of the patients were treated with combination therapy recently, based on the risk stratification. However, there is some of the patients should go to the initial monotherapy. So what kind of patients go to the initial monotherapy? So this is a list of using a monotherapy. And when we look at this list, mild patients are included, like CCB responders or well controlled with monotherapy for 5 to 10 years, or very mild patients. But in this list, case more than 75-year-old having a risk of HFpEF, and case suspected to have PVOD are included. These characteristics are matched with the characteristic of SSc PAH, suggesting that we have to be careful about the screening of the patient with scleroderma PAH, and whether they might have the ILD or a cardiac involvement. We need this screening. Also, the establishment of the follow-up system is also quite important. For early detection, general practitioner and non-PH center can do that. But for the specialized medical service, PH center must do it. And then quick referral and collaboration is very important for the quick response, quick treatment for the patients. Also in the guidelines for the specialized medical services, policies to evaluate the risk of having PAH should be considered in hospital managing the patient with SSc. So we have a lot of requirement, especially in the specialized medical services and PH centers. So thank you very much for attention. This is my summary slide. So thank you.
Okay, thank you very much, Professor Yasuoka. So talk is open. So comment or questions in the audience. Oh, yes.
Does that actually does the treatment of pH differs in the lupus and MCTD versus systemic sclerosis? I couldn't hear properly. The difference in the treatment once a pulmonary hypertension occurs in lupus and MCTD, it differs from the classical systemic sclerosis.
I'm sorry, you mean the difference of the treatment?
Treatment part.
Treatment in SLE and compared with scleroderma.
Yeah,
Is that
yeah.
correct?
You showed high dose steroid, cyclophosphamide. What
Mhm.
about what about others like you have drugs like PD4 inhibitors and other drugs?
Thank you very much. It's a very good question. And in scleroderma, we do not use any immunosuppressant for the treatment. We usually use the vasodilated pulmonary PAH drugs for the treatment for scleroderma. So we usually use ERA or PD5 inhibitors or prostanoid for drug.